Welcome, everyone, to another edition of EMDR Chat with Curt and Michelle. I'm Dr. Curtis Roundsen.
And I am Dr. Michelle Gottlieb.
And Michelle, normally when we do these chats, after you introduce yourself, you introduce the topic we're going to be discussing today. However,
Right.
That's going to be different now.
Oh, really? What are we going to do?
Well, because you're the topic.
Ooh, goody. Okay.
Well, at least what one of your expertise is in
Yeah.
this topic, and that is the use of EMDR with chronic pain, even chronic illness.
Yeah.
More and more we hear about these issues of chronic pain, chronic illness, and we talk quite a bit in our trainings and in our groups about the use of EMDR with something like chronic pain. And you've been doing this for quite some time, and I was curious, is there anything in particular that got you interested in even trying to utilize something like EMDR with chronic pain?
Well, two things really. First, someone very close to me had a lot of chronic pain in their life, and I found out much later that there had been a history of abuse that I didn't know about years ago, and I found that curious. The other thing that really got me into it were my clients, right? Is that how many of our complex PTSD clients, and all of our clients are complex PTSD, but how many of our complex PTSD clients also have chronic pain and chronic illness?
And autoimmune diseases, things
All
like
of
that.
All of that. And so I started to, as I said, be curious, and I discovered Dr. John Sarno, who in modern times was our originator of this thought that I'm about to tell you is not modern, but modern times, the idea of the mind-body connection. Folks in the East have known about this forever. West was still relatively new, that when there is something wrong in our mind, our heart, our soul, and we could not deal with that trauma at the time, it gets stored in our bodies. Now, we talk about in EMDR therapy, we talk about TICEs. A trigger, a trauma, or a target equals an image, a cognition, emotion, or body sensation, right? So this has actually always been part of EMDR therapy, but maybe not pointed up as much as what I do with my clients.
Yes, and I always think how the language we use often says things, the idioms we use, things like a punch in the gut.
My heart is broken.
My heart is broken. My stomach went to my throat. Pain in the neck, pain elsewhere.
Right.
And how, like lower
walking
back.
on eggshells,
Yeah.
all of that. It really comes through in our language, doesn't it?
Yep.
Again, this is not a new concept, but that we don't necessarily acknowledge it, I guess.
Yeah. And oftentimes, chronic pain, chronic illness, they are very real, are they not?
Oh my goodness, yeah. It drives me crazy when the medical doctors say to our clients, "Oh, this is all in your head." No. It may have originated as a trauma, but the pain/illness is a real pain/illness. Like pain is pain is pain is pain is pain. The brain does not necessarily recognize is the pain caused by something physical or something emotional. It is pain. So that's why it drives me crazy, because the doctors don't know what to do with them, because the medical doctors, they don't respond to medical treatment. IBS is a perfect example. The docs give them all kinds of meds to settle their stomach, but they still have IBS because the stomach is protecting, taking care of, holding the trauma. And until we really work through the trauma and all the things that happened because of the trauma, their stomach's still going to be there doing its work.
You remind me of a case that I worked with a few years ago where a patient came in with chronic IBS symptoms and other kinds of diagnoses. And she had spent her whole life never, ever setting a boundary or speaking up for herself. And as we began to do work with her, not about her stomach, but about the trauma that she's had in her life, she began to find words, and those words were connected to anger.
Right.
And as she began to be able to express that anger, her symptoms in her stomach began to dissipate.
Right. But again, it's not just in her head the way the
Right.
docs would say it, right? It's just the way I frame it for my clients is that, using your client as the example, for all of the reasons she couldn't speak,
Right.
right? Probably because her family of origin, her relationship, she could not speak. So
So
all of those,
she was swallowing her emotions.
right, all of that got swallowed, all that got stored in her body. And so once it was, you guys reprocessed enough and she was able to start speaking, it's almost like the poison is coming out of your body, right? And she was able to lead her life and not have chronic IBS anymore.
Now, in general,
Mm-hmm.
is the standard protocol what you utilize, or are there some specific adaptation or modifications that you may use at times?
You know what? I'm going to ask that question, but I'm going to go backwards and get back to that question
Okay.
because I think this will help. At this point, most people are familiar with the ACE study, the Adverse Childhood Experiences Study, right?
That's right.
Tens of thousands of patients have gone through it. Think about what it says. Adverse childhood experiences, scale is 1 to 10, or 0 to 10, I guess. I can't imagine anyone having a 0, but good for them. And the higher their ACE score is, adverse experiences in their childhood, the worse their health is on every level. And that could be heart disease, cancer. I mean, you name the disease, and it's worse the higher your ACE score is.
The conclusion was that adverse childhood experiences was the number one cause for death, disability, and illness in adulthood.
Now, think about that statement. Not that they fell down and broke their leg, but that the trauma that was involved in from being a sexual abuse survivor, from their parents, there being domestic violence in the home, whatever it is, that's what the trauma was. That's what the wound was. So, thinking about that, as we target the actual trauma, not the illness, not the pain, but the trauma, using standard protocol,
Mm-hmm.
the way we do it on anything. If our client comes in and says, I had a car accident, I'm going to do standard protocol. If a client comes in and says, I have chronic pain, and I do their history, and I find out their ACE score is a 7, and there was domestic violence, and she was a survivor of sexual abuse, and I'm targeting all that trauma.
Right.
And I'm checking in with them. This is where some of the adaptations happen. During phase 8 reevaluation, I'm checking in to see week to week, are there changes happening on those physical symptoms? And that can be, initially when we start, of course, it can get worse before it gets better because we're actually delving into some of those emotions. But are the symptoms worse? Are symptoms better? Is the pain better? The analgesics they take, have that changed and not been as strong of meds or as often of meds? And that's where we start seeing that our clients getting better on all levels of TICES, right?
Yeah, and I think you touched on something very important in the reevaluation phase 8, is the number of times the clients will come in and say, no, I'm the same. It's nothing's changed. And then you begin asking those specific questions like, well, how are you still taking as many medications?
Yeah.
They'll say, oh, no, I haven't taken them much this week at all.
Right.
And then they begin to see, oh, there are changes, because so much of EMDR is organic. It's subtle in the beginning,
Right.
and it takes that kind of reevaluation specificity in order to really get to it.
And my client who taught me to do the phase 8 reevaluation this way, because don't we learn so much from our clients?
Yes.
He was a chronic pain client, and we were targeting all of his trauma growing up. And he said, well, when are we going to start doing my pain stuff? And I went, ooh, okay, let's check in on that. And I said, okay, I know you were taking opioids. What's your, what dosage? What are you doing now? He goes, oh, now I'm just taking over-the-counter medication and not as often. It's like, oh, well, we're really targeting it. You really are feeling better, aren't you? So, and that's where we can point out to them, yeah, there's been a lot of progress made, a lot of healing made. And I do want to stop. And first off, 2 things, and it's so important. I so honor my clients who have chronic pain and chronic illness. This is not easy to live with. It is not easy to deal with. They have been disregarded in so many ways. So if you have a client walk in the door with chronic pain or chronic illness, don't do it's just in your head. It is trauma that has been stored in their body. And so please give them as much honor as you do with any other diagnosis. And the other thing that it's really important to remember as you work with this population, the difference between structural and the mind-body stuff I'm talking about. If I have a client who did break their leg, that is not a mind-body illness. That's not an ACE score. That's not that's a structural issue. The bone is broken. Okay.
Right.
And to recognize that. On the other hand, there have been some really interesting studies that have been done on stuff that we thought was structural and causing the pain, but actually that's not what causes the pain. And my favorite study about that one was a bunch of orthopedists were given MRIs of people of their backs, and they had to diagnose based just on the MRI who had chronic back pain and who did not. And some of them had stenosis, and which is the narrowing of the spinal cord. Some of them had the discs were bulging or bone on bone or whatever, right? All the stuff that we hear about in MRIs.
Right.
They could not tell by the MRIs who had back pain and who did not.
And if I recall the studies, I mean, some of the MRIs looked almost identical. They were different patients, but had similar kinds of injuries or problems. And one person might have chronic pain and another one did not.
Right? Because it's not about the back.
Yeah.
It's about the heart and soul and mind and trauma.
In a sense, in medicine, although I'm not a physician, but there's this thing called referral pain. You injured one part of your body, but it shows up in another part of your body.
Right.
And it's sort of the mind-body similarity as that referral pain. It's in your body, but it goes through, it starts in your brain, in your mind. And it gets worked out in your body or stored in your body in that kind of painful form.
And speaking about that, this is another thing that we often see during phase 4, 5, and 6 with the reprocessing phases. We ask our clients at the end of the set, what do you notice? And they often will say, oh, I have a pain in my head. All right, go with that. And then what do you notice? Well, I have a pain in my neck. Go with that. I have a pain in my stomach. Go with that. And it starts moving. Mm-hmm. And there is and that referred pain that you're speaking about that we see in the medical world, there is a connection about like it's a shoulder injury, but it's my hand that hurts. Well, there's nerves that are connecting, and there's a reason why that might happen. But when it's my hip and then my neck and then my head, there's no connection. There's my stomach, right? There's no connection. That doesn't make sense from a physiological standpoint. So when I see the pain moving throughout the body, it's like, got the buggers on the run. Yeah, let's go, That's
right. You're chasing the little sensory memories down.
That's right. That's right. Yeah. And so what I want y'all to take from this is, for one of the many things and about all of this, is that when you have a client come in with chronic pain, chronic illness, don't assume there's nothing you can do. Don't assume you're just going to help them, palliative care, right? Just help them cope. Don't assume that. Look at their trauma history. Do a good treatment plan on their trauma history. Not necessarily their chronic pain, chronic illness history, but actually the trauma that they went through, the family of origin, whatever. And then do a really good phase 8 reevaluation about checking in with them and seeing what's changed. But people and I've done it too, and I'm like, I know better. You do a whole treatment plan about when'd your back start hurting, and the first time it hurt, and the worst time it hurt, and all this other stuff, and their back isn't getting any better no matter how much reprocessing we're doing, because we're not targeting the right thing.
Yes, I remember a very interesting case years ago where a woman came in with lower back pain, severe back pain, and her doctor said there was nothing wrong. Mm-hmm. It was in her head.
Right. Yeah.
Well, the pain was debilitating, but we began to do that work. And this was one of the patients that I often talk about, in that her reprocessing was totally in colors.
Huh. Uh-huh.
I see yellow falls and it's moving like in a river of blue. And I stepped back and it was movement. So I said, go with that.
Right.
And I remember at the end of the session, she looked at me and says, what are we doing here? And I said, I have no idea.
Uh-huh.
But there's movement.
Right.
And that's that's how she processed. And at the end of our treatment, her back pain was gone.
Right.
And underneath that, we found out she was working a job where she had to be scientific and analytic, and she really was an artist at heart.
Oh, yeah. Uh-huh. Well, that's like, my client, talking about movement, and as clinicians, we do not need to understand what the heck is going on, just as long as
Right.
there's movement, right? I had a client, she was not a chronic pain client, but she was a rape survivor, and we targeted the rape. At the end of the first set, she said, I have a weird feeling in my feet. Like, I don't know what that means, right? I'm not going to try and analyze it. I just said, go with that. And then it was in her calves, and then it was in her quads, and it going up her back, and then coming out of the top of her head. By the time she got to stuff coming out of the top of her head, her SUDS, her subjective units of disturbance, was a 0, where we'd started at a 10. She never once talked about the rape. Not once.
Yeah.
Right.
She reprocessed the body feelings. Yeah.
Right. Exactly. It was totally on a body level. So, and that's another example of our staying out of the way, staying away from our assumptions of what reprocessing is supposed to look like, and whether they do it in colors or just weird feelings in their head. I did have one chronic pain client who, after every set, it's like, it was my forehead. Okay, go with that. Then it was the side of her head. Go with that. Then it was the other side of her head. Go with that. Then it was the back of her head. Then it was the top of her head. Right? And guess what? Her SUDS dropped every single time, and her phase 8 reevaluation every time came back with being able to live her life more and more and more.
Yeah. Yeah. When it moves like that, as you and I have talked before, if there's an injury, the pain's going to stay pretty much localized to the where the injury is. But when it begins to move like that, I'm going to assume it's a memory that we're chasing down, and we just follow it because it's movement. We don't have to know why. Yeah. As you think back on your work with chronic pain, is there any other kind of, I'll tell you what I'm thinking. Okay. And that is, every once in a while I read about someone wanting what's the IBS protocol for this? Do we have a protocol for, broken fingernails or something?
Right, yeah.
And I sit back and I look at that and I say, it's all standard protocol.
Right.
And I'm sure you see that in the work you do.
Well, and actually, I think the best example of that, honestly, is it's a story that one of our trainers tells. She was on some chat, EMDR chat, and talking about the trauma was about seeing a gecko or something. And someone said, oh, can I have that gecko protocol? No, it's all standard protocol. It's not a specific gecko protocol. It's not a specific IBS protocol. It's standard protocol. Now, think about some of the cognitive interweaves we may do. Those may be more specific for the population we're working with. For example, with this population, they are infamous for being very perfectionistic and very analytical, very much intellectualizing everything. So sometimes when I've done, what do you notice? They've told me their thought, they've told me their thought, they've told me their thought. I'll say, well, what are you noticing physically or emotionally, right? Trying to get them to even acknowledge there's something, below the brain. And to even look at their body. And I say it deliberately, what do you notice physically or emotionally? Because I'm wanting them to recognize physical and emotional are connected.
That's right.
So that's an important one. The other thing that I often need to do with this population for cognitive interweaves, they are often angry at their bodies. Their bodies have let them down, right? And to be able to say as a cognitive interweave, to thank your body, honor your body, let your body know now, as a hopefully functioning adult, you are capable of dealing with whatever life gives you. Your body no longer needs to protect you, but to thank it and honor it. And that is a really weird thing for a lot of our folks.
Absolutely. And I think that's a great place as our time comes to an end, Michelle, to bring conclusions to today's chat. Thank you so much for sharing your expertise.
Thank you.
And participants, thank you for listening in. Until next time.
It's great to see you guys.
Yeah.
Come back next time.
Next time. Thank you so much for listening. Thank you, Michelle.
Thank you, Curt.